Good morning, good afternoon. Welcome to today's webinar, Improving Health and Reducing Homelessness Through Cross-Sector Partnerships, Insights from California. My name is Meryl Schulman, and I'm a Senior Program Officer at the Center for Healthcare Strategies, and I'm pleased to be moderating today's event, made possible by the California Healthcare Foundation and co-hosted by the Better Care Playbook. Next slide, please. Just for reference, today's webinar is being recorded and slides will be shared via email following today's event. I also believe that my colleagues are putting a link to the slides in the chat as I speak. Next slide, please. So as the title suggests, today's webinar features two California-based teams of healthcare and homeless services organizations that have been working together to improve the way care is provided to people experiencing homelessness. The work of these teams is a product of a California Healthcare Foundation funded initiative called Partnerships for Action. And our first agenda will be to review an overview of that initiative. Following that overview, we'll share high-level lessons learned from Partnerships for Action about what it takes to build and sustain cross-sector partnerships. From there, we'll hear from the two teams that I mentioned. The first team is from the coastal San Luis Obispo and Santa Barbara counties, and the second team works in a more rural, inland, and mountainous community in Tuolumne County, California. Following those presentations, we'll invite our colleague Lauren Hardin from HC2 Strategies to join today's presenters in a panel discussion. And we'll wrap up today's webinar with audience question and answer. That being said, if you have a question, please submit it via the Q&A box located at the bottom of your screen. Next slide, please. Okay, so on this slide, you can see today's learning objectives. Broadly, we hope that you learn more about Partnerships for Action and key findings related to cross-sector collaboration. We hope that you better understand how healthcare and homeless services organizations in California are working together to develop and sustain cross-sector partnerships. And lastly, we hope you learn more about the benefits of cross-sector collaboration and why it matters, both for the organizations that are partnering and for the communities that they're serving. Next slide, please. So before I talk about Partnerships for Action, I want to share briefly about the Center for Healthcare Strategies, or CHCS. CHCS is a nonprofit based in New Jersey that works with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes for kids and adults served by Medicaid. Since 1995, CHCS has worked with just about every state in the nation, and we also work in partnership with federal agencies, health plans or Medicaid managed care organizations, providers, community-based organizations, and people served by the Medicaid program. At CHCS, we do our work in a number of ways. We provide technical assistance and training, we host learning collaboratives, conduct environmental scans, and all of that work is aimed at creating more effective care models, advancing more efficient policies and programs, and ultimately and hopefully improving health equity. Next slide, please. So I mentioned this at the top of the webinar, but the Better Care Playbook is a co-host for today's event. The Playbook, if you're not familiar, is a resource center for evidence-based and promising practices to improve care for people with complex health and social needs. The Playbook regularly summarizes new journal articles, evaluations, and implementation tools, all with a focus on translating evidence and research into practice. If you're interested, you can explore more at thebettercareplaybook.org. Okay, so if we go to the next slide, we'll learn more about Partnerships for Action. Partnerships for Action, or P4A, as we like to call it, was a 2-year initiative funded by the California Healthcare Foundation that was focused on improving care and ultimately health and housing outcomes for Californians experiencing homelessness. This was done by supporting cross-sector partnerships of healthcare and homeless services organizations. We worked with an incredible advisory group that helped us select 8 teams across the state of California to participate in the initiative, and each team received grant funding from CHCF to work on a discrete pilot project. The 8 teams also participated in a learning collaborative, which included a series of in-person and virtual learning sessions, and the teams received technical assistance from CHCS and contracted subject matter experts like the National Healthcare for the Homeless Council, HC2 Strategies, whom you'll be hearing from later, Clearfield Consulting, the Corporation for Supportive Housing, among others. Since this is a national webinar, I want to acknowledge for those not working in California that this project was strategically supported at a time when California is reforming its Medicaid program through an initiative called CalAIM. CalAIM created new benefits and opportunities to help Californians experiencing homelessness access healthcare, housing, and social services. And the success of CalAIM rests to a large extent on cross-sector partnerships. In many cases, these are new relationships, new partnerships, and they require an unprecedented coordination between health and homeless services sectors. So that's the broader context that's happening in Medicaid in California right now. Next slide, please. So another important aspect of Partnerships for Action was a developmental evaluation, which was conducted by our colleagues at Mount Auburn Associates. From that evaluation and from our collective observations over the past 2 years, CHCS, CHCF, and Mount Auburn Associates have started to formulate lessons on cross-sector collaboration. We're working on a brief that will detail more about these findings, but today I'll touch upon them at a high level. So center collaboration around a project. We learned from the pilot teams that the project work was crucial to the outcomes of their partnership. The projects provided an intentional space to test new processes, collaborate, and it helped keep the teams focused and engaged. Build relationships. This lesson probably is not surprising to anyone on the line, but relationships matter. Authentic relationships allow teams to better work together as they can understand how their partner sees the world, their values, and what motivates them. Relatedly, we were reminded throughout this initiative that spending time in person and in each other's spaces is critical, and virtual just isn't a substitution for in-person connection. Create mechanisms for accountability. This is how you get work done. So we found that the Learning Collaborative itself was a mechanism for accountability. We had monthly meetings with each of the pilot teams to help their projects stay on track. And many teams had their own team meetings, and some created work groups to divvy up roles and responsibilities. Identify opportunities for broader systems impact. To actually impact systems change, systems of care, organizations that are working across sectors need to think about how their work can inform systems change. This could be done by analyzing community resources and needs and aligning a discrete project with those findings. And it can also be done by including individuals like leaders or entities like continuums of care that have the potential to influence systems. Employ boundary crossers. So this refers to hiring people who have experience working in the sector you are partnering with. We saw through Partnerships for Action that sometimes this happens organically as people seek new job opportunities. And sometimes we saw distinct positions created to facilitate cross-sector collaboration and integration of services. And we'll talk more about this notion of a boundary crosser later in today's presentation. Embrace dynamic partnerships. Partnerships will and should evolve and change over time. A number of teams have turnover, which require them to be nimble or hire or engage new staff. And a few teams that we work with realized that a perspective was missing from their team. And so they work to engage a new organization or new individuals to round out their team. And lastly, but importantly, involve the community. At the end of the day, we're doing this work to improve care and service delivery for people experiencing homelessness. And so those people should be advising, guiding, and leading any efforts that impact them. For this project specifically, CHCS had a number of project advisors with lived experience of homelessness. And across the board, we heard from our pilot teams how valuable and meaningful that was to have their voices in the room informing the project. So again, stay tuned for more lessons on this project when we release the final brief in the coming months. Next slide, please. So without further ado, I'm very pleased to introduce today's speakers. I'll keep my introductions brief as presenters will share more about their organizations. But first, we have the team in San Luis Obispo and Santa Barbara counties. Amelia Grover is the manager of social work at Dignity Health. Amelia is joined by her colleagues, Christine Nichols, who's a program development specialist at the managed care plan SenCal Health, as well as Jana Nichols, who's the executive director of a homeless services organization called the Five Cities Homeless Coalition. Then we will hear from the team in Tuolumne County. Mark Dyken is the executive director and co-founder of Resiliency Village. And Mark is joined by his healthcare partner, Jasmine Rice, director of operations for a local tribal federally qualified health center called Matheson Memorial Health Clinic. And last, but certainly not least, you'll hear from Lauren Harden, Chief Integration Officer at HC2 Strategies. So with that, I'm very pleased to turn it over to Amelia Grover. Amelia, it's all you.
All right. Hi, everybody. We're actually going to have Christy start out with the first half of the slides, and I'll talk about program activities after that. Thank you for having us.
Hello, everyone. I'm Christy, and I will be co-presenting with Amelia today. And then Jana Nichols from Five Cities Homeless Coalition will join us for the panel discussion. Next slide, please. Okay, so to give an overview of the region, we are San Luis Obispo and Santa Barbara counties. And as you can see there on the slide, we are on the central coast of California. To give a brief overview of the region, what you need to know is housing is expensive here, both renting houses, buying houses, it's expensive, and this directly affects the state of homelessness in the region. Our local statistics and reports from last year show that people experiencing homelessness reported that the main reason for homelessness was lack of affordable housing, followed by loss of employment. So as we know, homelessness directly affects people's health. So to help address the intersection between health of our unhoused community members and the actual housing situation, the Partnerships for Action team consists of organizations that serve the homeless community, organizations that provide health, and organizations that provide the health insurance. So as you can see there, we have the healthcare providers first, and that is Dignity Health, which Amelia works at. And we also had a homeless health social worker, also from Dignity Health, named Christina. And then for the managed care plans, and managed care plan is health insurance, it's Medicaid. And in California, Medicaid is called Medi-Cal. And that's where I work. SenCal Health is the Medi-Cal provider for both counties, San Luis Obispo and Santa Barbara County. And then we had 3 different homeless service providers. And these providers, they provide emergency shelter, they provide services, they provide transitional housing, case management. And that is Five Cities Homeless Coalition, which Jana is a part of, Capslo Prado, we had Jack Leahy from them, and Good Samaritan Shelter, we had Sylvia Bernard. Next slide, please. Okay, so the problem statement and project goals. We had 3 main ones, and we found that in the area, we already had strong partnerships. But the problem with the partnerships is that we had different processes and vocabulary. I'll give an example of that in a moment. Another problem was lack of continuity when it comes to a client's needs, whether it's, they have health needs and behavioral health needs and insurance needs and housing needs. And to keep that continuous, there's a problem with a lot of breaks in the continuity there. And then lastly, we had siloed systems of care between organizations. So as an example, there may be a client who has diabetes, and so that client needs health from a doctor, a primary care physician. That person may also needs substance abuse treatment or behavioral health or mental health treatment. So they have a counselor for that. The person also may be looking for housing. They need a case manager from that. And then you have the Medi-Cal that can help pay for all of that. But each of those organizations has their own separate database. And the two databases don't talk to each other. An electronic health record doesn't talk to a homelessness software record, and vice versa. And so the main goal to put all of that together was to build a continuous process between homelessness providers, the healthcare providers, and Medi-Cal to meet the needs of the unhoused community members. So to talk about how we did that, I would like to turn it over to Amelia Grover.
All right, next slide, please. Thank you. So I want to say that, you know, one of our main objectives here, and the way I kind of conceptualize and think about this as we were even writing the grant, was like, we need glue. We all have our systems of care that help support these individuals along the continuum, but we need some kind of glue. And we knew that CalAIM was on the horizon, and we had a, you know, sort of some idea of what that might shape into. So we also saw this project as, okay, well, we know that's going to be on the horizon. It's starting to come into our community. We're starting to understand what that looks like. We want to help to shape that as well. And so we really developed this homeless health social worker as an attempt to be some of that glue. Like we described it as, we really need someone who's a physical link. So there's a picture of Christina right there. She's our wonderful, amazing homeless health social worker. Christina is a licensed clinical social worker. She had worked in acute care in medical social work for some time before this. So she had a really good understanding of the needs of the homeless individuals, people experiencing homelessness when they came into an acute care setting. You know, an acute care setting is obviously a very high level of care. So we were seeing kind of the worst of the worst situations. But we knew that once the person left our door, it was sort of a baton handoff. It wasn't that kind of that bridge that we needed to help people move over. So even though we had good relationships with our post-acute providers, including our homeless service providers, we were missing that glue. So Christina stepped into that role, and she became sort of that physical link, that individual who was helping people transition from one level of care to the next. Part of what we started to, like when we first went into this, is we said, okay, we really need someone who can follow these individuals who are coming out of an acute setting and are going back into an unsheltered situation, or are going to eventually be in an unsheltered situation, and we need someone to follow up. So we said, let's go where people are already going. Let's partner with our homeless services providers. They know these people already. They're out in the community. Let's go out together and follow up with some of these individuals wherever they discharge to, and let's see if we can put our brains together to try to figure out and make an appropriate care plan. Try to continue that care plan from the hospital into the post-acute setting, and then try to merge the homeless services case management plan with the healthcare plan. We went into it with a mindset really of tertiary prevention strategy. Something has happened and we need to try to address that thing that has happened. Some healthcare event, some health event has occurred. We need to provide the follow-up. And that intention, I think, still strongly exists in this role. We want to make sure that when someone has had an acute medical event, that we are not contributing to the to that event becoming worse, that we're trying to address that in a tertiary prevention strategy mindset. But what we realized was over time that we also had a lot of value in the primary and secondary prevention strategy realm. Let's get to things before they occur or as they're beginning to occur. And so we'll talk a little bit about that. We began to develop shared knowledge, vocabulary, and goals. We saw that many of our the things that we wanted for people aligned. I'm going to move quickly because I know we've got short on time, but one of the major things that came out of our partnership was we decided, okay, one of the main venues that we're using to combine this healthcare and homeless services partnership is through street medicine. So we tapped into and partnered with technical assistance from National Healthcare for the Homeless Council and CHCS to have a street medicine convening in our community. And so we had a bunch of street outreach providers and healthcare providers come to the street medicine convening and just discuss our services. I mean, at most basic level, what do you do? Where do you do it? What population do you do it with? How do you hand off to each other? How are you recording your data? And so just kind of getting a broad understanding of like what's going on in our community and who's doing it. Through that discussion, so much rich conversation came out about partnership in general, healthcare needs, unmet healthcare needs, silos that were occurring. How are we linking all of this to the CalAIM initiatives? And really this discussion of knowing that we cannot just be responsible for what we own. We need to be empowered to see what we are responsible to for our patients that we're serving mutually to our community. So it was really this positive shift in mindset in our community. Next slide, please. So just to talk a little bit about our accomplishments and our impact. I mean, first, having our homeless health social worker was our first accomplishment, just to have that individual who was that glue. And by creating that person who was expert in navigation of people experiencing homelessness across the healthcare continuum, we then gained this organizational understanding. So we knew that we needed partnerships to make this position successful, but what really blossomed was this respect and understanding that we really need each other. It required close working partnerships with homeless service providers because we know it's often the work of these providers that are the stabilizing force that allows the patient then to focus on their health needs. So we knew that we needed both of us to be in the mix here. It also allowed the healthcare continuum to have more faith in the treatment and the care of the individual because they knew they had this clue now. A skilled nursing facility knew that they could accept this patient into their care and they would have support in discharging that individual to the post-acute setting because they had Christina coming in and helping with the care plan, but they also had Christina working with the post-acute services to say, hey, this is what's happening in the skilled nursing facility. How can we try to provide something that's appropriate for this person on the outpatient side when they're ready for discharge? And it created this bi-directional relationship. It wasn't just that we were pursuing the healthcare needs of the individual, but it was also that prevention secondary, a primary and secondary prevention strategy where our partners in the homeless services community were coming to Christina and saying, hey, we've got this weird thing going on with this person that we're working with. This is what we normally would do. What do you think? And so it started this really good partnership around how do we prevent things from occurring before they get, to the point where the person is in the hospital and really focusing on that prevention, that liaisoning work. And through that, we were able to develop the shared vocabulary. We were able to teach each other, gain a greater respect. Next slide. I'm kind of going into my next slide here, which really, I want to just highlight that I think there's a difference between building relationships and having partnerships. We know that, I think we use the word partnerships really kind of loosely maybe, but we know that we've always had these relationships, right? But we developed partnerships. We had a mutual accountability. We were able to formalize these relationships that we had into a shared identity that the community recognized, that our patients and our clients recognized, and that we began to own. We had this mutual investment. And through that, we gained a lot of trust. We increased our collaboration with each other. Our goals we developed we realized were often very similar to each other. And we had this increased accountability. Our conversations became more clearly focused on a shared strategy. Like what happens to you ultimately happens to the people to me and the people that we're serving. So let's align in what our service provision. And we really did embrace that identity as a subject matter expert and we're welcoming to develop that cross-sector influence and advisement to other individuals outside of this partnership group on how they could begin to address some of these issues. And with that, I'm going to sum it up because I know I'm just at my time. Thank you.
Thank you, Amelia and Christy. That was awesome and a great overview of the work that you've been doing the past 2 years. And I just want to acknowledge that I love that last point that you made about, it's not just about building relationships, but it's about really building effective partnerships. And we're going to revisit that later in the discussion. So I'd now like to turn it over to Mark and Jasmine in Tuolumne County. Mark, take it from here.
Thank you, Meryl. It is really a pleasure, and I'm pretty honored that we were chosen from all the great teams that were part of P4A to present. So Resiliency Village and Matheson Memorial Health Clinic, we partnered together. And these are some of the things that we already had in common. We are both really local solutions for our rural community. And that's a big part of our challenge is we have unique challenges as rural service providers. And especially now, there is a lot of misperception in our community and probably everywhere about who's homeless, why they're homeless, and what their challenges are to get back into housing. And so for us, that was a big part of what we wanted to do is get really good information so people could understand this better. And so we would have something to really hang our hat on when we went out and tried to change some perceptions on that, how people felt about it. And the populations that we serve together are people experiencing homelessness or at risk of homelessness, and the low income folks who are enrolled in Medi-Cal, which of course aligns really good with that realignment called Cal-AIM. What's interesting in another way about our partnership is that the Matheson Memorial Health Clinic is a project of the Chicken Ranch Rancheria Miwok Indians of California. Around here, we just call them Chicken Ranch. And they've been doing what they do for many, many, many years, whereas Resiliency Village was a brand new startup private nonprofit trying to address something that our county government just and the one and only incorporated city, they just don't address. So we had a few things that we had to do just because of where we live. Next slide, please. So our partnership goals, as I'd mentioned, we want to, just like everyone else, and like Amelia and Christy were talking about, we really could see the needs of these folks that we know that we will not be able to serve all of them with housing. We'll try to get to as many, bring them into shelter, run them through our programs, but they need people to meet them where they are. And as I mentioned, we want to collect this data on their living conditions, their medical, dental, and mental health concerns, so that we can not only be efficient with resources, but again, to really inform our community, other providers, and policy and decision makers about what's really happening with the people that live without shelter. For instance, and I saw it was in one of the questions earlier, the age of the people who are living outdoors. Remarkably high number of seniors, and I think that number is going to continue to grow. We also were very interested in identifying the gaps in service, why people don't get the care they need, because so often we, from top-down type of perspective, we come up with solutions to a problem without actually involving the folks who are experiencing that problem. And so that's why we wanted to get out there and talk to those folks and make sure that if we come up with a solution, it's going to be something that works for you. It was Albert Einstein who said that if someone asks me to solve a problem, I'm going to tell them I'm going to spend 95% of my time understanding that problem and getting the right data, and 5% of the time coming up with a solution. And so we really wanted to have that kind of base for any solution we come up with. Then to move forward, develop a plan jointly with input from those who need that service to close that gap. And this, when we first started this, and when we first sat down to talk about an application, I actually worked with the CEO of the clinic, John Voss, and we sat, we had several really interesting conversations on the way to this, and we were joking about, well, if everyone would just listen to the two of us, we could solve this, no problem. But what we realized is that, and this had been a goal of Matheson before, was to get outside the clinic walls. What I didn't know as a homeless service provider is how difficult it is to bring that service out, not just the physical difficulty of it, but rules, regulations, things like that. And then we want to be able to share these findings to improve this collaboration and maximize the service delivery. Again, just like what both Angela and Christy referenced, is that we can't be siloed, and a problem of this magnitude needs to be addressed at the magnitude of the problem, which is all hands on deck across all sectors. Next slide, please. So how we work together, and here's just a couple photos to show you how rural we are. That's the Resiliency Village main house. We house between 8 and 10 people in there, depending on if kids show up. You can't see a neighbor from where we are. We're 15 or 20 minutes from the nearest grocery store right there. There are disadvantages to that, but advantages in terms of resetting and being in a calm, peaceful place. And that's just one of the many clinic doors that you can walk through to get service through Matheson. Matheson is just constantly expanding and moving into behavioral health. They run a really great substance use disorder program at the Red Feather Clinic. It's walk-in, and of course their original clinic. So, and I think you guys are moving into dental too. I'm gonna kick this over to Jasmine in just a second. So, but this is what we did. We planned and collaboratively applied to participate. Then we attended, as was mentioned by Meryl, all the things that were provided to us as members of this collaborative. And for us as a brand new organization, this was such an amazing get for us to be in this, to learn from people like Amelia, Christy, Jenna, who's going to talk a little bit later, and the other teams. I was just constantly amazed at their success and what they were able to do. And we designed and implemented this survey. We developed a street outreach program and worked with some local providers on that. And we've coordinated our referrals much better. So we get folks over to that clinic who need that. And we get some referrals from them from folks who are needing shelter. Next slide, please. So our service delivery looks like this. We have an intake and an assessment of someone. They're assigned a case manager. Of course, we're a housing first provider. And then our resource referrals, so we're connected in a lot of ways, but medical was a little bit of a gap, especially, again, that's a rural issue where you have limited number of providers, and reasons why, you know, if people don't like one hospital, or we have had clients who are literally banned from going to the hospitals because of previous behavior. So that takes a little bit more to get over on that. So we do that resource referral, we find the right places for them. And transportation, as you can imagine, is a big deal with being as rural as we are. We don't have city bus systems or anything like that. So that's a really important thing for us to be able to provide. And then when we get them to Matheson, these are the kind of things that they can be served with: medical, dental, behavior health, and substance use disorder. Next slide, please. So this is some of what our team achieved. We did design, implement, and complete that survey. And we used folks with lived experience to carry out the survey, which we thought was really important to get the right amount of data. And I think we're going to talk a little bit more about that later. And it might not seem like a lot of people, but to have 68 people sit and talk with our interviewers for sometimes up to 2 hours, we got a lot of information that no one else has, including ACEs assessments for almost all of them. Our improved access to healthcare services for the homeless community in collaboration with other community partners, and building that trust, having them see us, be part of this, be out there, working with what's called the HOST team, Homeless Outreach Street Team, that the city of Sonora has. So, and Jasmine and other folks from the clinic have been part of that, as well as Resiliency Village team members. Then we've continued to develop these collaborative service plans, getting outside the clinic walls. I'm gonna have Jasmine talk a little bit more about what their plans are with vans and a mobile clinic. And then for us, this increased awareness. Again, we're in our community, the understanding of who is homeless, why they're homeless, and what they face is, it's a big barrier for a lot of folks to even, if I would dare to go so far to say, like they feel like humans. And this has strengthened our cross-sector collaboration and tangible health outcomes. And Jasmine sent me a message. If she's on, I want to kick it over to her to just talk about those vans and about especially what she was able to learn from being a little closer to the service providers of homeless services.
Thanks, Mark. I think Jasmine is having some connectivity issues, and it looks like we just lost her.
Okay.
So we
Well,
can.
I'll try and stay on time and move to the next slide, and then I'm sure we can get her for panel discussion and to bring that up.
Perfect. Thank you.
It's a really important part of what we're moving forward to. Now, I swear we did not collaborate with the previous presenters on what we learned. But obviously, what P4A did for, and I'm going to guess for most of the teams, is we did learn that these effective partnerships require this kind of communication and shared goals and spending time with each other, that we must have this community input and collaboration. If we really want to have an impactful solution, we've got to get out of those silos, as was mentioned before. And this was something that Jasmine brought up, and I hope she can speak to it later too, is understanding the work and challenges of our community partners. For me, it was understanding the challenges that they have, just bringing that the services outside the shelter walls. I just was unaware of how involved that is to be able to provide that kind of service. And certainly, as was mentioned by the previous team, this really has strengthened our strategic approach to future challenges. And it has, especially when we had a local convening, it sort of elevated the status of, especially of Resiliency Village. Matheson is well established, but more and more people started to see us as serious providers of this service instead of maybe dreamy nonprofit that wanted to help people. And that's it from me for now. Thank you all very much.
Thanks so much, Mark. I was trying to keep an eye on if Jasmine was able to hop back on, but it looks like she's still trying to log back into the event. I don't know if you saw, you're getting some round of applause and hearts from the audience. So at this point, let's transition to our panel discussion. Emily, we can drop the slides, and I want to invite Amelia and Jana and Christy and our colleague Lauren Harden, who I mentioned is the Chief Integration Officer at HC2 Strategies. Lauren has been a technical assistance provider, an advisor for this project, and she works with an array of communities in California and nationally on cross-sector collaboration. So we invited her to attend to broaden our lens beyond California today. Okay. I think for my first question, I'll start with the team in San Luis Obispo and Santa Barbara counties. So Amelia, maybe I'll start with you. You mentioned this about relationships, but we know that relationships are fundamental to cross-sector collaboration or partnerships. Can you speak to how your team approached relationship development, and how your team's relationship, or as you said, your partnership has evolved over the 2 years that you've been working together?
Sure. So I said this a couple of times, but I think, to elaborate a little bit, we've had strong relationships for years. I've worked for Dignity Health now for almost 10 years, and I've known Jana for most of that time. I think and we've always had really good baton handoffs to each other. Hey, we've got this situation going on. We need some help on the post-acute side, and to make sure this patient gets out of the hospital safely, help us figure out a good solution. When we developed this grant, there was an intentionality of us to say, we're going to mutually invest. And I don't mean necessarily financially, although the grant was incredibly helpful to that. But we're going to all say that we want to see this individual, this homeless health social worker, be something that all of us see as beneficial to the services that we provide to our community. And so our partnerships began to evolve a little bit because we had this now shared accountability to one another. We had this mutual investment, and through that we began to develop this new identity, not as I'm a healthcare provider, I'm a homeless service provider, but as agencies that were interested in that connection, that nexus between healthcare and homeless services. And that sort of became, I think, an identity that we embraced as a team and as a group, but also I think in our community was receptive to this group of people are subject matter experts on how do you address these issues across this care continuum, and how do you do that in a way that's effective. And so, a lot of it is anecdotal. I think opportunities for our program are going to be, how do we look at data that might be developed to help us to see some of this stuff. But in the first, I think, 90 days of the program, we saw an 80% reduction in our hospital visits. So we do know that this partnership and this person that we mutually invested in was effective. We know to some degree, right? Because we were really relying on each other. So our relationships evolved. Our partnership became one of a shared identity that I think really helped us to gain traction in the community for the people that we're serving mutually.
Amelia, can I just ask a follow-up question? And you started to get at this, but like you said that you all started to have this shared identity, and you saw through some metrics that the work that you were doing was working. How else do you measure that, or can you measure that you're moving from beyond this like relationship to a true partnership?
Yeah. I think it's tricky, and I would say we're kind of open for discussion around that. This was a 2-year partnership project, right? And at the end of the 2 years, all of us were like, but we need to keep going. Like, we feel like we barely just started. And so even we were talking about how can we find some other, we knew our relationships would continue and we hope that identity would remain. But when you have something that's holding you accountable to a certain, degree, it helps you to, continue that work in a cohesive, intentional way. So I think that's kind of up for what we're trying to evaluate and look at now. I know Jana has some input on that.
I'll be brief. There are 2 things. One is I haven't taken a Sunday night call from Amelia since we started this project. And it was at least a monthly, if not an every other week event that we were problem solving on Sunday night for some specific case. So just anecdotally, I could leave it there. But as an example, even this morning, I was talking to one of the other service providers on the team, and we were talking about some changes with regard to how we do outreach. We've had some new issues around encampment resolution, and the impetus to standardize how we do our work so that we have a mutual expectation and understanding, oh, they're going to do it this way, we should also do it this way, so that at least the community has a general understanding of this is how we as the service providers are approaching this issue, as opposed to everybody figuring out on their own, I think is a primary example.
That's really helpful. Thank you both. Christy, I'm curious, do you have anything that you'd like to add on this notion of how do you approach relationship development and how the relationship from your perspective has evolved over the course of the project?
Oh yeah, it has evolved exponentially, I think, because being from Medicaid, Medi-Cal, well, a big part of it is CalAIM, and that now Medi-Cal can cover a lot of those services, which has really helped with the relationships, because now it's pulling us in, and the organizations have a way to really to pay for these services and to expand the projects. So our relationships, like before, I didn't really know any of the people individually, and now I do know and can call if needed. Hey, we have a client has come to us. Let's hand off here, because I know that there is now a system where that can happen. And the Partnerships for Action was definitely instrumental in that.
Thanks, Christy. So Jasmine, welcome. I know you had some connectivity issues. Don't worry about that. I'm curious if you're able to share, Mark had teed you up for this, but I'm curious if you can share just at a high level about the work that Matheson has been leading in partnership with Resiliency Village to develop a mobile clinic and a street outreach model for your community, just so the audience has that context.
Of course, and I apologize. Welcome to a rural area. Our internet is very unpredictable, unfortunately. But I know it's been spoken about multiple times, but kind of as we were working through our partnership with Resiliency Village, we learned how much CalAIM does tie into working with the homeless community. And so we were fortunate in the fact that kind of congruently with this project, we had received funds through a PATH, excuse me, cited grant. And that grant was intended for us to build our CalAIM team, which we've done. We've got a CalAIM coordinator, we have a nurse navigator, and we have two CHWs, which are community healthcare workers, kind of a new position to the outpatient world, similar to what Amelia was talking about. It's kind of like that social work glue. I kind of feel the same way. So with that, we also were granted funding for a mobile unit. Unfortunately, we quickly learned that our lag time in manufacturing that unit is around 16 months. We did not want to halt the project. I mean, that's just a long time frame. So we were fortunate in the fact that we had excess funds. We used those funds to purchase 2 additional vehicles, and so we could keep that street medicine concept going. And so our street medicine team consists of an LCSW, a nurse practitioner, one of those CHWs, as I was previously speaking of, and an RN. In addition, we participate, and I apologize if Mark touched on this, and I'm so sorry for leaving you high and dry, Mark. We have an RN and a CHW that participate in our local homeless outreach team, support team. And what that's done is it's bridged that, like you guys have previously spoken to, that relationship and that trust. We're starting to gain that with the homeless community, and that's been a huge for us. So yeah, that's kind of high level. So we intend to use the mobile unit and the street outreach to continue to work with the homeless community. We would like to bring the mobile unit out to Resiliency Village on a quarterly, monthly, weekly, whatever we ultimately determine basis.
That's great, Jasmine. And I feel like something that we learned from you all and from some of the other teams is just the importance of a dynamic partnership. And you all were a great example of that when you found out, okay, it's going to take much longer to create this mobile van. Now we need to pivot and find another strategy and work together to get these services to our community. Lauren, I'm wondering if I can turn it to you. So something we learned from Partnerships for Action that I talked about at the beginning of today's webinar is the value of discrete projects in catalyzing and grounding cross-sector collaboration. But eventually, organizations need to spread their work to the healthcare and homeless services systems to have a broader impact. Can you speak to how organizations can move from collaborating as a group of individuals to actually influence systems change?
Definitely. And everyone here has told great stories about the foundation of that. So as a nurse and a facilitator, I get to work with communities around the country. So this isn't just a California thing. And it's also not just cross-sector collaboration isn't just only helpful in healthcare and homeless response. It happens with many other populations around the country because of the benefits that the group has called out. So one of the foundational things that helps it to scale is to start to collect data. And Amelia was talking about that. There are actually evidence-based scales you can use to measure the impact of collaboration, but pulling together the story on how are you impacting quality of life for the people you're serving, how are you impacting cost and unnecessary utilization of systems really starts to set a foundation and brings more partners to the table. What I see in bigger cities is they set up regular tables to do cross-sector case conferencing. So all of the cross-sector partners that intersect with the population, not just the people in this early partnership, but everybody that's working on this comes together to help individuals solve for complex scenarios, but also takes the lessons and captures process improvement opportunities. So I've seen that in Oregon and in St. Louis and in Memphis, where they took those lessons and realized in our community, some of what's happening to people is because we don't have any recuperative care. Or some of what's happening to people is we don't have the right discharge pathways in the hospital. Or some of what's happening to people is they don't have transportation to get to the care they need. And then the community uses that data story to fund some of those process improvements. And it also creates a lot of satisfaction amongst the providers, like you've heard here. That generates interest from private funders, I've seen payers fund the work. I've seen health systems fund integrator roles to keep it going because of that 360-degree impact. That's very possible to do.
Thanks, Lauren. Jana, I know this is a topic that you appreciate. I'm curious how your team has thought about moving your work from a distinct project or projects to one that can impact the health and homeless services systems.
It's interesting to me. I mean, we've talked a little bit about the fact that we had to learn each other's language and understand what we did, and obviously our relationship with CenCal through the CalAIM project was clearly part of this. There were two distinct things that this project did for our organization. One was just the discovery of opportunity and the ability to see what other communities were doing, look at how they were problem solving some of the same issues that we were, and really, several communities were far ahead of us in many regards. And so just the idea that we could do business differently and be seated with some of those ideas of how to do it was incredibly beneficial. The other aspect was within my organization, how we came to recognize the nexus between homelessness and health. And in fact, my organization, we've gone through an entire paradigm shift. We have been a housing provider for years. So that has been our mission. Sheltering is almost secondary to us as getting people and keeping people in housing and how we do that. But we've come to realize that it isn't just about housing and it isn't just about income, but one's health status is a critical component to their long-term stability and quality of life. And so literally we have taken our board and our entire organization through a complete different shift in lens of understanding why we have to care about health, as opposed to passing it off to Amelia's team. It is as critical as a component of our services as anybody else. And so it isn't somebody else's job anymore, it's ours. And obviously we cannot provide all of that. And so how we deliver that response, how we fulfill that responsibility is entirely dependent on our partnerships within the community.
Christy, I'm curious how you would respond, particularly given your perspective as someone who works in a managed care plan.
Well, going off of what Jana said, it just brought to mind, there's another organization that was part of our group. They're not here today, but Capslo, where also melding the health needs with people that are experiencing homelessness. And they've started recuperative care, offering recuperative care beds. And other organizations are now also offering recuperative care beds. And to be able to be from a managed care plan, from health insurance, to be able to help with that now is great. And it really, again, helps build the relationships and the partnerships. And so it's just creating more services for people that really, they don't have these services available anywhere else. So to be able to work with these organizations and say, oh, great, you have these beds and they can be recuperative care beds. And we're going to bring in one of the nurses or doctors from the neighborhood clinics, the federally qualified clinics, to come in and help with that. It really does take collaboration and teamwork to be able to bring all that together. People don't often think about health insurance with homelessness, but we're really becoming a big presence in California with the CalAIM addressing homelessness.
Thanks, Christy. So Mark, I'd love to bring it back to you. I think you gave, you said a quote, was it Albert Einstein? Something about spending 95% of your time understanding the problem and then 5% of your time on the solution. And one of the ways that your team did this was surveying and having in-depth conversations with folks who are unhoused in Tuolumne County. I'm wondering if you can just share more about why you chose that approach, and how the surveys with the community have influenced your partnership with Matheson.
Certainly. Again, just to come back to this point about homelessness, for a lot of people, it is an urban issue, and it's often viewed that way, and that's kind of a lot of the bigger presentation of it, and even say smaller cities, but it's not generally considered a rural issue. It's harder to see, and we don't have those kind of aggregate numbers like Tuolumne County. Our population in Tuolumne is right around 50,000 people, and so to have 1,500 people a night be homeless seems like nothing compared to some of the other counties or places, but by per capita number, we actually match up to, say, San Francisco and Sacramento, some of the bigger cities here. And so that impacts us in a different way because we have fewer avenues to address it. We have fewer resources, and we get strained that way. So to have real accurate information about who's out there and why they're out there and how we could change this for them, I think, for us, it was just a really important starting point, because so often, again, solutions it's a top-down thing, and the people who are going to receive that solution, they may not be able to access it for a number of reasons. And Lawrence put this in the chat, and I know we talked about it, so the people who we sent out to do this were two people with very recent lived experience. In fact, one of them is still living without shelter and lived without shelter conversation that for most people out those for a long time, they often feel unseen. They certainly feel unheard. This is one of their barriers to care, and a lot of mistrust. And have someone sit down and this was a 40-question survey plus an ACEs assessment if they agreed to it. And they would spend sometimes 2 or more hours talking to these folks. And that got us information that no one else has. And really, sometimes to present that information, it is an eye opener for folks. And you do see everything that you might think and everything that a high ACEs score would indicate in the folks there. What people don't understand is how long the person has been living with that pain to get to that place. I worked in schools before I came here to do this as a homeless education liaison. And I never heard one kid say, I want to grow up to be homeless. I have never heard that. And there's always a story, and it's pretty much always a trauma story behind that. And that, I think, is really misunderstood, especially when you hear people say, oh, they want to be there, or they don't want to access the care. So, and then just to follow up one more thing about Lawrence's question, everyone on our staff has some degree of lived experience.
Thanks, Mark. Lauren, I have one more question for you. Just to change gears a little bit, and you referenced this, but we saw through Partnerships for Action the value of employing people who could actually bridge the connections from one sector to another. And I mentioned this, but sometimes we just saw people, getting in who worked in the homeless services sector, and now they work at a managed care organization. Other times we saw teams creating a distinct position to facilitate cross-sector collaboration. You referred to this as that integrator role. Can you speak to the value of these boundary crossers, so to speak, and what that role looks like in practice?
Definitely. And I love that role so much. I'm terribly biased about it. As a nurse, almost 15 years ago, I was leading a complex care service where I was the boundary crosser. I learned caring for the people with the most complex needs, that alone the healthcare system was not going to be able to solve it. And the most important thing to do would be to partner with behavioral health providers, substance use providers, the homeless response system, even the police and EMS. And by collaborating, we were able to help each other. We were able to help individuals faster and create a very strong web and network. The same thing is happening now around the country, whether it's with older adults or whether it's with kids in foster care or whether it's homeless and healthcare integration. Having someone whose focus is really that integration really accelerates it, and it gives somebody the bandwidth and the vision where they have time to really focus on the relationship building and the follow-up and the process improvement work and capturing the lessons. In Tulare County, the health plans funded a role like that. Iris Gitcho is the CalAIM coordinator. And we linked an article about her that got created out of this P4A project as well. In other parts of the country, sometimes health plans are funding that role because they're seeing the benefit in the outcomes. When I was doing it, it was funded by the hospital because it was reducing unnecessary utilization, because it saved time for the providers in the emergency room and inpatient. And it really increased people's well-being and positive feelings in the workforce because they had support. And then the relationships that were built across the community built all kinds of other follow-on benefits like the teams have described here. So there's a lot of different ways to fund it, but that role is emerging as critical. And there's even an entire movement around hubs. So having an organization hold that role, somebody put that in the chat, a backbone kind of organization that takes on that as a benefit for the community or a benefit for a certain population, they'll hold that role. But it isn't necessary to have a paid role to start this. You can start it like the team did, realizing that it's worth the time investment because of the improved outcomes, how much time it saves all of us, and the satisfaction of actually having your shoulders broadened and having others to work together to actually improve things for the community. So there's a real diverse panel of things happening, but I have a lot of seeing a lot of new payment emerge for these kind of roles.
Thanks, Lauren. So I'm going to wrap us up with one question for each of you, and then there are a bunch of questions in the chat that we're going to try and get to in our remaining time together. But before we turn to the audience questions, I'd love to hear from each of you. What's one thing that you wish you knew at the outset of your partnership that you know now? And for you, Lauren, if there's something that you want to underscore to the audience on building effective cross-sector partnerships, we would welcome that. So Amelia, is it all right if I start with you?
Sure. One thing I wish I knew at the outset of our partnership was, I think, I'm trying to say this, it's a positive thing, but it requires a lot of work and energy. You know, it's not just that you can come together and meet, you know, around a table once a month, although that is significant and helpful and useful. But we discovered even with that position, we could have 5 of those positions that were across each of our organization that were boundary crossers. And so it takes a lot of very intentional effort and energy and, you know, a shift away, not away, but a shift into what the intention of that focus is, and not all the busyness you have of your own organizational demands that are going on. And so it does require a lot of good, but, you know, a lot of energy.
Thanks, Amelia. Jana?
I think what I would say is it's okay to acknowledge that you don't know. I was very fearful of playing my cards. You know, I kind of keep my cards close to the chest. And we had to be fully transparent about what was not working as well as what could work. And as I said, the opportunity to come together not only as a team but with our other teams to learn from one another was tremendously beneficial. But you had to accept that you didn't know it all, and you had to be willing to be somewhat vulnerable in in trusting those relationships to really get to the core issues.
I love that, and I'm seeing a lot of head nods, so there are many people who agree with you, Jana. Christy, what about you? What's one thing you wish you knew?
I wish I had known the other organizations' systems before this, and which was one of the problems that we identified working in a silo, and I was definitely in a silo. And had I known beforehand how things worked, as Jana said, I didn't know. I think we could have, or I could have picked up faster and gotten going. And we did a lot of great things, but maybe have done a bit more, but I needed to take that time to actually get out of the silo. So I wish I had known how things worked across the board beforehand.
Thanks, Christy. Jasmine, what's something you wish you knew?
I somewhat concur. I mean, first, I'd like to say that my biggest I wish I knew before is that I was naive to the issue that we have in our county. Like Mark said, it's very, you know, tucked away in our rural space. And I honestly wish I knew that Mark and what he represents. I wish I knew him longer, because I feel like our partnership, we can truly make a difference. And especially, I mean, you guys saw his passion. I mean, that's real, and it is making a difference in our county. And I wish I knew that sooner. But in addition, I wish I knew the entities that we've learned through CalAIM and through this process, how, you know, that we currently have, and how we can collaborate to help these patients, because it's more than just prescribing a medication. It's whole person care, which is a great concept with CalAIM. We've got the resources, it's connecting the patients to those resources.
I love that, Jasmine, and I feel like you're touching upon like something that's very actionable for the audience, and just like getting to know the people that you're trying to serve in your community, and also just reaching out to new people or new organizations in your community who you don't know yet. Thank you. Mark, what's something that you wish you knew?
Well, Jasmine, you're so kind. This is a very, very specific to me about this. I'm kind of known for punching above my weight. So I take on things that I don't always think them 100% through. But Lauren rescued me on this one. But yeah, I wanted to gather data. What I wish I knew was what it takes to compile data and put it into a presentable form. And I was really fortunate that Lauren rescued me and connected me with Surinder down at USC, a medical researcher who, you know, I didn't know there were such data nerds about this, who was excited to see just, you know, all of these pages of questions answered, and he compiled that into a database that we could actually use and access, and then help make a presentation out of it. So, and then again, maybe it's good that I didn't know, because if I had, I might have jumped into that. Getting the data was a pretty big challenge, but there I was sitting with this box full of completed surveys going, how am I going to put this together and be able to present it? So I probably should have known more about that before I jumped off that ledge.
Thanks, Mark. And Lauren, why don't you round us out? What's one thing you want to impart to the audience about cross-sector collaboration?
So 3 words, just do it. I wish I could go back and tell myself when I was starting, don't let organizational culture or resistance get in your way. When I started, I got in a lot of trouble, and people told me, you can't do this. It's not legal under HIPAA to do it. It's not allowed. Those things are normal that come up when we start boundary spanning and crossing the street and really coming together. So don't let those normal things get in the way, and look for maybe 1 or 2 people. Start small. Who else cares about the population and cares about this work, where you've got a good support system and you can start to learn together? You don't have to boil the ocean and try to serve an entire population the first day. Build that link together, and you'll have a strong foundation to really take this forward and really make a huge difference for the clients you serve in your community.
Thanks, Lauren. Okay, we are going to turn to audience question and answer. Thank you all. I don't think I said that. Thank you all for the amazing presentations, and also for the very insightful panel. So our first question is from Victoria, and I think that this is specifically for the San Luis Obispo and Santa Barbara team. But Victoria is asking, what benefit did you see in hiring a social worker into the role of the homeless health position over hiring a community health worker?
Yeah, so I will say, and I think Jasmine mentioned this, coming from a healthcare space, and I've been in a healthcare space for 10 years, community health workers are a very new thing in that space. So really the work that was done in an acute care setting, similar to the work that we wanted to accomplish outside of the hospital, was done by a master level social worker or a licensed clinical social worker. I would say there's room for both. I think that the benefit of having a social worker is they're trained in system assessment, and they're trained to think and understand the clinical barriers that might be presenting across the care continuum within the individual, but also in the the meso and macro space as well. But there were a lot of times that we partnered with our community health workers that were slowly building up in our post-acute space, because sort of simultaneous to this, we were becoming an ECM provider. We had these community health workers. We had a Promotores program that we were partnering very closely with. And so in reality, while this grant funded that individual, there were a multitude of staff that were contributing to the efforts, including the community health workers that might have been in the homeless services space as well. So I would say traditionally healthcare uses those like clinicians to be involved in some of this, but I think there's benefit to having a multidisciplinary effort.
And
If I could just jump
yeah,
in
go ahead.
very quickly. What I was going to say is, my case managers are very close to that community health worker. They have some of the same training. Having someone with that next step of expertise that truly understood the medical system was critical. Because we can figure it out at the base level, but when you really have to understand the system, that's where Christina's expertise was enormously helpful, and it cross-pollinated and helped to train my staff.
Mm-hmm.
And just building on that, Jenna, Victoria, like a second part of that question is asking, like, do you think a community health worker would be successful in such a position? I'm hearing from you that it was valuable to have a social worker in the role, but I'm wondering how you feel. Yeah, go
I
ahead.
think as the program evolves and continues, we're going to see community health workers needing to be a part of that effort. I think there's still value in having the clinical teams there because of the way they interpret what's being presented before them. We partnered with a nurse as well. And so, even though this funded the licensed clinical social worker, it was also a nurse, and it was, a bunch of other clinical staff, and then a huge, tribe of community health workers that were helping to actualize that work. So Christina was doing a lot of the interpretation, the assessment, and then using the community health workers, using Jana's teams to help kind of execute and make those wheels spin. So could a community health worker do that work alone? No, I think it really requires a multidisciplinary effort. And I think that's something we really learned is this project funded that individual, but it was really funding the catalyst of all of these other initiatives that were surfacing and that will be continuing to surface through CalAIM.
Thanks, Amelia.
And I know you want to move on, but I think it's important. So San Luis Obispo County is the second least affordable county in the country for a metropolitan area of our size. Studio apartments are $2,200 a month. What we're talking about here is a workforce availability. So yes, we're going to need community health workers because we're not going to have the capacity to recruit someone of a higher level. And yes, we need that expertise to help lead the effort, if that makes sense. So they don't all have to do everything. And we certainly aren't going to have the capacity to recruit for the highest level of expertise. And that's where bridging the gap and actually building a system of tiered expertise is important.
Yeah.
So a different question, Mark, I saw that you started to answer this via the chat, but I'll ask it in case there's more you'd like to add, or Jasmine, if there's anything that you'd like to add. But Charity is asking how you collaborate with local tribes in your community. Can you speak to that? And Jasmine, welcome your take as well, given that you all are a tribal FQHC.
Yeah, I mean, that's the obvious way we work together is, you know, the clinic and all of its attached services are tribal entities. But we, especially the Chicken Ranch Band, has been a big supporter of Resiliency Village, and we've worked together on a couple other projects. We would take referrals from them. They're a really small band. There's only like 40 people in the tribe, but they're very, very successful. They operate one of the most successful casinos in California. So they are a huge support to our entire community. So it's a real integration that way. And then there's another casino and another tribe, up the hill a little bit, and we take referrals from them. Same thing. So I myself just really feel comfortable and happy to have any partnership and work with our Indigenous neighbors and collaborators, because I really believe in the wisdom of how tribal governments work to conduct themselves. And especially if we want to really get back to it, what we're doing here is an equity project. And this for our neighborhood, tribal equity is a big deal. And they've become some pretty huge gorillas in our community, which is really cool for me to see. But also the concept of looking ahead 7 generations. And that's what this work is about.
Thanks, Mark. Jasmine, is there anything that you'd like to add on that front?
I think that we are we are lucky in the fact that both tribes, I mean, are extremely embedded in our community. They don't operate siloed. They're embedded. They care. They want to help. They're out there to build relationships. And Mark has done a great job building a relationship specifically with our tribe.
Thanks, Jasmine. So there are a couple of questions related to like technology and data from the audience. I'm going to do my best to not lump them together, but try to articulate them. So there's one question, and I have a feeling that this might be for the team in San Luis Obispo and Santa Barbara, but they're asking where did it go? Sorry, folks, the question just disappeared. Are you using technology to coordinate care at all? That is the first part of the question. And the second part of the question is how, if at all, you are using HMIS data.
So in our outreach efforts out in the field, we are using HMIS, including GPS monitoring, to both identify the individuals as well as mark their location of their living situation, so that we can either revisit them or document that we've talked to this group, so that if somebody else is talking to them, we know that somebody else was also there, et cetera, and documenting what services have and haven't been used. For those who are not in the homeless services business, HMIS is the Homeless Management Information System. It is provided by any number of software providers, but it is a requirement by HUD that we utilize that. So we are using that, and the GPS marking is a critical component of that. I mean, I'll let you talk and Christy talk about the integration of community information exchange, health information exchange.
Sure. So one thing I want to say is that we made sure, and we had kind of a difficult time with this in San Luis County for different reasons that were sort of out of our control, but we're still in effort pursuing this. But our Christina was able to get read-only access to HMIS. Ideally, that would be a bi-directional access, information exchange. but right now, at least we could have HMIS, look at HMIS. We also use the Fulcrum app and partnered when we were doing our street outreach, and we would mark certain encampments or individuals who needed follow-up care for medical needs. So we did use that tracking system to help us in our street outreach efforts. If Jana's team had somebody that they knew they needed Christina to come follow up with, they could track them with that app, and then Christina would see she needed to be able to go out with and partner with them on this many people. So we did use those type of technologies to help us to track and coordinate certain individuals and what their needs were.
Thank you both. Lauren, I have a question for you. In the chat, Beth is asking, do you recommend that some type of backbone organization is involved in initiating and nurturing cross-sector partnerships? I'm curious, like, how you would respond to that as someone who's done this work in multiple communities.
That's such a great question, Beth, and it can be so helpful if there is a backbone organization. But I do see communities get stuck on that. Like they think they can't start this kind of cross-sector collaboration without a big organization or a funded role. But the backbone organizations emerging, there are many different kinds of hub structures emerging. Some of them are holding things like doing contracting and billing and really operating as a managed service organization. Some are doing this as part of their community investment work, where they're taking on a role like this and they're convening partners and they're holding that structure. So it can be very, very helpful. In other parts of the country, like in St. Louis, there's a behavioral health organization that functions as the integrator and the convener. They provide some direct services, but a big part of their work is convening the whole community to do cross-sector work around serving the complex behavioral health population and working on system improvements. In Portland, there is a managed care organization where they've funded a position in that organization to convene people, facilitate case conferencing, and facilitate the process improvement. So there's a lot of different ways to do this, but the backbone organization can be very helpful for long-term sustainability.
Thanks, Lauren. Go ahead, Jana.
I think it's important to note that in neither of these models is the local jurisdiction, the local government, the convening body. And I don't mean that we don't have strong relationships with our governmental partners, but one thing I've learned is government is reactive, and it is very difficult for them to be proactive. And if we were to seek government leadership in doing this, it would not be nearly as dynamic or effective, quite honestly.
If I could add to that, in our rural area, in our rural setting, I'm pretty sure that we have influenced our government to act, because before we were doing what we were doing, there was nothing going on in homeless services. And until we started showing up at supervisor meetings and talking about what we were doing, being in meetings with they didn't even have a homeless solutions committee until we started our work and sort of made this an issue. And I've always wondered, do you guys ever get embarrassed about the fact that a private, tiny nonprofit is doing all this work and you don't make any contribution? So I'm waiting for that day, but we're one of the few shelters. We get nothing from our local governments or anything like that. So to Jenna's point, if we would have waited for them, there would be nothing happening. I don't know, they've jumped on board with some of the recent flood of money that they're almost required to take. But I don't think without these nonprofits and small organizations starting out and showing some leadership, I don't think they would have done it.
So I have, we have just a few minutes remaining, and I want to try and get to at least 2 more questions. There's an interesting question in the chat, and it's directed for the more urban communities, but I'd welcome anyone's thoughts on this. Beth is asking, how do you overcome what can be like the sharp differences in size and capacity that typically exist between the healthcare partner and the homeless services partner? And I think like what Beth is getting at is like the power that healthcare can have. So how do you navigate those power dynamics within a community? Lauren, I see you nodding, so go for it.
Yeah, that's again a really great question. So definitely first around culture and approach. So how is this cross-sector collaboration designed? But what I've seen in communities where it's done well, so there's very intentional structures in the meetings and how people come together. And Mark, I saw these were just natural. And with Chicken Ranch, they were principles of how we set a shared table and how we message that everyone matters. And there's a place for everyone's voice here, so that the size or the money behind the organization doesn't determine who speaks loudest or is heard the most. And then a perspective of humility. So the organization with the most resource, whether it's the health plan or the healthcare system in a large community, really shouldering costs for the benefit of the population in the community to start, and intentionally sharing resources to expand capacity. So a very like early example from the work I was doing when I started meeting with homeless response, the health system was so mad because they wouldn't accept people at the shelter who had COPD. And when we started doing cross-sector case conferencing, it was because they didn't obviously have woven in healthcare services, but also they didn't have the right flow of what could happen with the oxygen tanks, and they had nowhere to store them. So we were able to share our services to overcome that barrier, open up a lane for that whole population, and share things that we had that could be shared as resources. So increasing capacity and sharing from a place when you have more to share from. And then in the urban areas, really intentionally build an integrated network where you are outreaching and thinking about, is this table fully representing my community, not just the people I know the best? So really intentionally thinking about that. And then Lawrence is such a great advocate and voice for this, but thinking about also including people with lived experience at the table, because it balances it out for the whole system.
Go for it, Jenna.
One of the things that we've learned through CalAIM, because they provided a lot of TA independent of this project, was bringing the various providers together. And what became difficult at one point was they kept bringing new providers into a conversation that had been going on already. And so there was a disconnect between people just coming into CalAIM and trying to learn the language, and those of us that might have been 6 months to a year ahead of time. And so the only advice I have in that is, in setting the table, making sure you're clear what the conversation is. And if you need to do a boot camp with some folks to get them quickly up to speed, do that, so that the providers that have greater expertise aren't fatigued by the continual repetition of the beginner's conversation.
A great point. So unfortunately, we have to wrap. Thank you all. What a tremendous conversation, and thank you to the audience for your questions. There was a couple of questions that we did not get to. Feel free to reach out to us at CHCS with those questions. If you'd like to chat more, we're happy to try and answer them or connect you to today's presenters or other folks who might be able to support you. So just before we wrap up, we want to call your attention to a couple of resources that are relevant to today's webinar. First, CHCS has released and will continue to release a variety of resources from Partnerships for Action and on healthcare for people experiencing homelessness in general. You can access those at our website, chcs.org. The California Healthcare Foundation has an incredible suite of resources that they have created or commissioned at the intersection of homelessness and healthcare. They're wonderful. Many are relevant to more than just California stakeholders, so encourage you to check those out. I mentioned the Better Care Playbook earlier, but you can check out that site for more research, evidence, and practice-based tools to support folks with complex health and social needs. And lastly, Lauren mentioned this in her talking points about that integrator or coordinator role. HC2 Strategies and the Institute for Healthcare Improvement put out a case study describing that role and what it looks like in practice. So if you're interested, feel free to check that out. Last but certainly not least, thank you again to today's presenters and panelists. You all were wonderful. Thank you to the California Healthcare Foundation for supporting this event, to the Better Care Playbook for co-hosting, our team at CHCS who does a lot of work behind the scenes to get this webinar off the ground, and thank you to each of you for joining. I hope you have a good rest of your afternoon. Take care.